Call this meeting to order.
Oh,
Right.
ruin everything.
Yeah, I know. You don't know how many times I hear that in a day. So. All right, so this is the April 4th OEBB board meeting. If you could, I'm going to take roll. In fact, I've already done that. So Susan Miller is supposed to be online right now. Enrique's not here, and Susan Ricky Smith is not going to be here today. Everybody else is. So.
I'm here, Robert. Thank you. Online.
That's Enrique.
Oh, wow. Oh, so we have phone? Is that what it is?
Yeah, I think
We're okay. It's just the screen that's
They
not.
can, they can see us, we can't see them.
Okay, Enrique, I got you down. Susan Miller.
I'm present. Thank you.
Okay, great. Well, then we have as full of a quorum as we're going to have. So let's get started. All right. If you could, we still need to approve the meeting synopsis from March 7th, or if there's any discussion.
Move to approve.
Second.
Okay, all in favor of approving the synopsis from March 7th, signify by saying aye.
Aye.
Any nays? All right, we can move on now. So the first thing up is April Kelly's going to present proposed Oregon administrative rules changes for HRAs.
Thank you. And it's so nice to be here in person with you all and see you again after 3 years. I'm April Kelly. I'm the rule coordinator for PEB and OEBB. And so if you see me sitting here, I'm asking for something. So I won't read through, hopefully you read kind of the white sheet that I wrote out for you all. But I want to say about 6 months ago, we were contacted by an entity and by a member asking about our HRA rule. And so I kind of had to go into the archives and figure out why we did what we did. And then I contacted Mercer. We worked internally, contacted Mercer, and wanted to get any updates to anything that has any federal regulations with health reimbursement arrangements. And then we got some information from Mercer that led us down a path to wanting to open up a section of our rule that's currently very limited. And that is on page 2 of attachment 2, the definition of integrated general purpose HRA. Currently, we say in our rule that HRA that allows participants to be reimbursed for all IRS qualified expenses and is available only to eligible employees who are enrolled in an OEBB medical plan. And so that puts some of our membership kind of in a hardship where they are opting out of their medical plan, enrolled in employer-sponsored medical group coverage by presumably their spouse or their domestic partner, and then they are not able to use their funds because they're putting into a post-separation or a retiree HRA. And with guidance from Mercer, since we will still be within, the HRA will still be within compliance with the ACA, they recommended that if it's not burdensome to us, which it's not, that we go ahead and open this up. So I'm asking, I don't normally ask for temporary rules because we do have to inform the legislature at the end of the year for temporary rules. But I think, and staff thinks that moving this to a temporary rule and while we go through the rulemaking process would be a positive impact on our membership.
3 points of clarification.
Yes.
What does burdensome mean?
I would say, so somebody who is opting out of their medical plan, in some instances, employers put money into an HRA or give them money in their paycheck. So
okay.
if so,
you
somebody
weren't talking about OEBB administration.
Oh, yes. No, there's nothing burdensome to OEBB administration to open this up. Yes, correct.
Second, did you check and see whether there was any risk ramifications with our carriers? Do they see this as any?
I didn't. I actually just working with Mercer.
Okay.
Yeah.
And then the third one is there anything prohibiting us from just continuing as is?
There's nothing. Yeah.
Okay. Just covering all bases.
Yeah, I understand.
We have carriers in the room. Are there any concerns?
I'm not reading this right now. I would have to review internally to see if there are concerns. The same for KP.
Do you want to talk about the process maybe with the temp rules and
What do you?
just like it could be amended or,
So we could, if we didn't do a temporary and just approved to go through the rulemaking process, it's about a 6-month process. And in that we could work with the carriers.
Okay.
Yeah.
So
And that doesn't mean at the end, I could maybe not come back. I mean, that's just going through the process and that's not actually.
So April, is it possible that since the opt-outs are happening at the employer level, that this is already happening, that if they're opting out and they're opting out because they're covered by another plan, it's probably still happening anyway, right?
It's probably still happening. They just happened to check with us, and then the HRA company has put it, not an integrated HRA.
My understanding of my day job is that happens all the time anyway, so.
I mean, my thoughts are, along with the Robert said, I think people are doing it anyway. And the last thing I want to have is one of our members has an agreement with their entity that they're opting out, it goes into an HRA, and then they're not able to use it. Their reimbursement gets denied. I think it doesn't hurt OEB as a whole. It doesn't hurt the carriers as a whole. It's in the members' best interest for us to make it a temporary rule. And within that time frame between temporary and permanent, if there's an issue that we need to not make it a permanent rule, that would be appropriate.
And I could always I can always suspend or retract the temporary rule as well.
Any other discussion?
I move to go forward.
Second.
We have a motion and a second to adopt the changes as presented. All those in favor?
Aye.
Aye. Oh, I can't vote, so take mine away. Sorry about that. Any nays? All right, I think the ayes have it. Okay, thank you. All right. So should we continue, Ali? Are we ready? Okay. All right, so we have a main purpose here today. So we are going to, Kirsten's going to start the discussion on renewal responses and getting to our 3.4.
Great, thank you, Robert. And as you guys are noticing, we're still working out the glitch with this screen. So for now, we'll have to go off paper copies. We do. We have extra paper copies, so if somebody would like one, Maggie can hand one to you. Just let us know. Maggie, can you go take one to Georgiana, please? Anybody else like a paper copy? Hopefully we'll get the screen back, but in the short term, yeah, we see you. Okay, thanks, Jeff. Thanks, Cindy. Great. So we're going to take advantage of brain science today and start with some quick wins and build up our confidence. And then we'll turn our attention to benefit changes and RSR buy down. We'll take a look at wellness renewals. And then we wanted to bring a new program to your attention. We realize it's late in the game, but just given the magnitude of potential savings on the table with it, we at least wanted to put it in front of you for consideration. That's Moda's Copay Max program. We'll talk about that. John is going to talk about some disability options that the board needs to vote on, and then we'll assess next steps. And specifically what we mean is, did we vote on everything that needed to get voted on this month? And if not, then we would need to talk about, could we vote by the end of today? And then if not, we need to set a time to come back in April and wrap up. But I think we can get through everything today. I'll just cut right to the chase. Initially, the round 3 renewals came in a better position than round 2. So from my perspective, last month was the hard conversation. I felt like by the end of the last board meeting, we got ourselves to a place where we felt like, okay, we have some options in front of us to get through this renewal. Now with round 3 financials in front of us, it's an even easier job. And so we have less even in front of us to consider than last month. So that's a positive. Any questions? Otherwise, we'll jump into the CL. So something that we talked about with Kaiser. So we'll start with Kaiser. Kaiser's suite of medical initiatives are nationwide initiatives that Kaiser, the health system, is undertaking to improve and advance care within the healthcare system. We talked about last month, these aren't single items. It's not a menu of choices that the OEB board is going to vote on item by item. In fact, what we are asking the board to do is to just endorse the package that Kaiser's planning to implement at this point for the members. These programs fall into the categories of driving efficiency for OEB, members improving quality and increasing access. And they're all programs that we've seen before this spring. So Robert, I don't know if you guys have a plan, but I'm thinking we can vote as we go, or do you want to wait and do it all at the end?
I think with the discrete pieces, I think as long as they don't have the financial impact as long as they don't have a financial impact on our other decisions, I think it's fine to go ahead and vote.
That's great. Yeah, so the Kaiser package of changes, that's just part of how Kaiser's managing its overall renewal. It's not a separate financial impact from what we're already seeing in the main medical renewal. So it is just this set of clinical initiatives if the board wants to vote on those.
So we're looking at page 5, right?
Yeah, exactly. It would be page 5.
Move to approve the Kaiser Medical Initiative renewal package.
I'll second that.
Okay. We have a motion and a second to accept the recommended Kaiser Medical Initiatives renewal package. All those in favor?
Aye.
Any opposed? And Susan and Enrique, if you're going to have to speak up and let me know if you approve or have a comment or disapprove, okay? All right.
Thanks, Robert.
Great. On the next page, page 6, Kaiser was proposing 3 benefit changes with negligible cost impact. Colorectal cancer screenings to be aligned with the USPSTF, their naturopathy benefit for out-of-area dependents, and lowering the insulin cost share cap from $75 to $35. We could take these one at a time or vote on the benefit changes as a package.
I'll entertain a motion for either one. Or is there any discussion over any of these 3? Yeah.
I am interested in seeing the impact of opening, it seems to be opening services to a greater degree for naturopathy. I would like just a request from Kaiser Permanente for them to report back in a year what, and it's been said that it was a negligible impact. I would love to see what those numbers were, you know, this current plan year, and then compare them with what happens.
That makes perfect sense to me, to see if the impact was indeed negligible, right? Okay, good. Any other?
I move to approve the benefit changes for Kaiser Medical.
I'll second.
Okay. Any further discussion? No. All those in favor of adopting the Kaiser Medical benefit changes on page 6?
Aye.
Signify by saying aye. Sorry, I missed that part. Any nays? Okay, motion passes.
Great, so we have 2 MODA medical initiatives to revisit. The first one is a treatment for type 2 diabetes. It's a vendor called Virta that reverses type 2 diabetes through the keto diet. In year 1, it's an investment of about $100,500. In year 2, beginning in year 2 and beyond, we expect to see a net savings to the plan. The proposal would be to accept the recommendation to implement Virta and then fund the first year of the investment through the rate stabilization reserve.
And how about the second one?
And the second one expands language services to MODA members. It has a negligible cost impact.
I think we ought to vote on these one at a time.
These 2? Okay.
And I move that we accept the first one.
Okay. We have a motion to accept the Virta proposal. Seconded. Was there any discussion before the motion, or is there any discussion now? All right, all those in favor of adopting Virta type 2 diabetes treatment as part of for next year, signify by saying aye.
Aye.
Any nays? All right, that motion passes.
The reason I said that was because of the way it's funded.
Got it. No, perfectly appropriate. Yep. I'll entertain a motion or comments regarding the language services.
Move to approve.
Second.
Motion has been approved and seconded. All those in favor of approving the expanded language services offered by MODA or proposed by MODA signify by saying aye.
Aye.
Any nays?
Just one, I voted yes for this. It would be also, as I had requested for naturopathy, I would like to see, you know, in a year's time, what expense was associated with this.
Well, I would add also the member impact. Since it's indeterminate, I'd like to see what the impact is. Right. Okay, flip the page. All right, we have one proposal for vision program changes from VSP.
The proposal is to change the benefit frequency from every 12 months from date of service to plan year. No financial impact for that.
It makes sense. People think, did I get it during the year? People don't think, well, I got it in October of last year, so I go up to it. So this makes a lot of sense.
Any other comments or questions regarding this one? All right.
Move to approve.
Second.
This proposal has been moved and seconded. All those in favor of adopting the vision program changes from VSP signify by saying aye.
Aye.
Any nays? All right, that motion passes. Great.
You guys are all feeling positive and confident at the moment, right?
I was about to adjourn, so yes.
Right, let's just
A little bit more work to do.
Okay, so let's turn our attention to updated financials and the plan to getting to a 3.4% increase because we're close. I'm not exactly there, but we are close. We updated, so it's slides 10 and 11. You saw those last month, and we've updated now these slides with the round 3 updated financial information. So the highlights here, we know that our requirement to meet 3.4% is an annual requirement that we have to meet every year, and we do. But we also know that due to the nature of healthcare and the fluctuation with healthcare, that costs go up and then they go down, and it makes more sense from that perspective to look at cumulative increases over time. And so we just update this slide to show really how the plan has been running since 2017-18 all the way through now to round 3, 2023-24. So the cumulative increase, this is for all lines of coverage now and all carriers, is at 3.2%. And you'll notice where we're at now for round 3 is 3.7%, 3.74 exactly, actually. So we have about 0.3% now to make up through some combination. You guys will decide on RSR and benefit changes. Yeah. And then for people who prefer to look at things in dollars, we just have the next slide, which shows the exact same data. That's slide 11. The exact same data, but with dollar amounts. So you'll see starting with the 2023-24 plan year now, the OEBS program will be running a little bit over $1 billion. All right, so let's see where we're at. On slide 12, slide 12 shows the evolution of the premium increases this spring from round 1 all the way now to round 3. Again, by carrier and coverage. And that column on the far right shows the difference from 3.4%. So the story here is that the renewals have all improved. So MODA's renewal came down from 4.23 as of round 2 to 3.74. Kaiser Medical, it's in the middle there. Their renewal came down from 7.82 to 5.8%. For both Kaiser and Moda, the major driver there is improved OEB experience. So every time the carriers give us an updated renewal calculation, they look at a more recent period of experience for that. So as that experience period moves, it can improve the renewal calculation because we have one more month of experience rolls on and one more month of trend assumption rolls off. So when the plan does better than trend, we get a benefit from that, and we're seeing that reflected here. The Moda Vision was a decrease in round 2 of 2.48%. That's improved slightly as well, a decrease of 2.87%. Delta Dental went from 1.54% to minus 1.1%. Definitely getting some help with the medical renewal from the dental and vision. Kaiser Permanente's at negative 3% for their dental still and 2.51% for their vision. The Willamette dental renewal is down slightly to 0.85%, and VSP is continuing to extend their offer of minus 12% renewal there. So when we blend all those together, it's a premium weighted average actually, but when we blend them all together into one overall increase, we get to 3.74%. And if we look at the differences all together, the vision and dental offsetting that medical overage that we need to address, we're at a $3.2 million difference, down from 11.1 last month. So in terms of $1 billion, it's a small gap to close up. Any questions before we move on?
I don't remember seeing RSR balances in.
Yeah, you know what, Jeff, we're coming to those slides, the very next one, actually.
Skip over that.
Do these numbers assume no plan migration? Or is there any plan migration assumption in these numbers?
No, there's no plan migration assumption in slide 12. That's just the status quo renewals that everybody stayed exactly in the same spot that they're currently at. Yeah, and no benefit changes or RSR spend in those figures either.
Is the Mercer expectation for plan migration to be minimal, or is that your expectation?
Yeah, with increases coming in where they are, yes, we would expect minimal. And we're not doing, we're not going to try to vary increases by plan
I get that. I'm
this
just
year
saying
either,
that
so
you're
that can be a driver
just
of
making all these
migration.
numbers are assuming just minimal plan.
That's a quick question. So the state and federal taxes and fees are not part of the test, the 3.4% test, but they're still member facing and applied to the member. Was there a negligible impact this year as
Yeah,
far
there
as
was
the
no
change?
change in taxes and
Okay,
fees this year.
perfect. Thank you.
Yeah. Maybe the easiest taxes and
Yeah,
fee years in a long
yeah,
time.
we always get that question.
Yeah. We wanted to include slide 13 again, just to level set. This is a slide from last month, but just to level set before we start talking again about RSR and benefits, how the whole process holistically all fits together. So the first pillar really is this combination. We call it conduct negotiations with the vendors, but this is the whole discussion reflected in the movement and renewals from round 1 to round 3, where we work with the carriers over that period of months to do our due diligence on the assumptions, to talk about experience periods. The experience periods get rolled forward. Maybe there's some partnership concessions in there as well. The second thing we look towards is improving efficiency, scrutinizing opportunities within the plan to increase the quality of care or access for members or improve outcomes. One of our triple aim, one of the 3 pillars of the triple aim, benefit members and also reduce costs. We look to make benefit changes and spending out of our rate stabilization reserve after we get through those other two pillars.
Quick question for Ollie, actually. Where's our ending fund balance reserve that's separated between Moda and Kaiser? Where's that in this?
Is that on this future slide?
Yeah, so on slide 14, Bill, we start talking about the RSR. Yeah,
It's
so
not
the,
part of your framework. That's what.
you know, we had a very detailed slide on the RSR balance over time that we presented last month, and
But I don't think it included the ending fund balance reserve, right?
for the rate stabilization reserve, we did have a slide. It's just a
That was for the
footnote now.
hospital- That was for the hospital cap stuff, right?
No, so the RSR balance is 35.9 million going into 2023-24. Is that what you're asking?
That's,
No,
yeah. That's from the hospital cap, yeah.
That's from the hospital cap. I'm asking about the ending fund balance reserve.
There's an OEB stabilization fund reserve that OEB's had from day one that grows basically on interest earnings every year.
I get it. I'm just saying, why is
yeah.
it in this framework?
Well, it's a little bit different than the RSR funds, but I can give you the number.
Yeah.
Yep.
Can that be part of this framework?
Yeah.
There's nothing preventing that, right?
No.
That's what it was there for. Right.
So also out of that.
Partially, yeah.
34, how much of it's Kaiser and how much of it's
Yeah, so
Moda?
that's why I said, what's the separation between Kaiser? I know Motives was higher than Kaiser's.
I want to say 21 and 15, 21 Moda, 15 Kaiser.
Because that's just the fluctuation of spend when we overestimate, underestimate kind of thing. And now that we're this close, that.
Yeah,
that's close.
They're different sub-accounts of the overall stabilization fund, but, you know, like I said, the other one is the sub-account it's started in day one from basically holding funds for 2 weeks at a time and interest earnings that, yeah.
I'm just asking why we're not having that in our framework.
This was set aside specifically for risk stabilization. So the other one is like unused funds, but we can combine the accounts. It's not a problem. You can use it.
You have to keep the Moda and the Kaiser parts of that separated, right?
Yeah.
So you can't really just combine it.
For the RSR funds, yes. And but for the OEB stabilization sub account, that's like some old federal funds, interest earnings, unused program. Yeah. Unused admin funds, a lot of things have gone into that. So it's a different sub account.
That in the past, right? But it's not.
Yeah. You can use it to stabilize.
Exactly.
Yeah,
Right.
exactly. Yeah.
And we're at 0.3% off here. Now that money is in play, in my opinion anyways.
Yep. Yeah, we can definitely report that along with the RSR funds and just separate it out. But yeah.
Money invested?
It's not. It's got to be held in the state treasury. Basically, we can't invest state funds, so unfortunately, it earns.
Is it LGI?
It's in like a savings account, really. I mean, it earns less than like a 1/4 point interest. Yeah. Yeah.
Wow.
At least for that. In me, and I know I've kind of said this in the past meetings, but RSR to me is for long-term systemic changes that affect ongoing in perpetuity good choices. The ending fund balance is where we collected more money last year, so we're going to use it to pay down this year. That's how I thought about it. Just right.
So going back to when we first established the RSR, it was because we had an unusually low, and we knew that if we took the whole low renewal the next year, we'd be vulnerable. So that's the only reason we established an RSR, and our goal was to spend that down at a reasonable rate to ultimately get rid of it. It wasn't our intention to have that. So I wanted to make sure we were all in agreement that that was still the principle that we're our guiding principle. The second thing, as I look at this, I would just like to ask the question, is if we're 3.2 million short and we've got 15 million roughly with Kaiser, and we brought their renewal down closer, spent that on them, we are spending less than 1/4 of their RSR, and that was kind of part of our discussion, is that we would keep it under 1/4, and that would get us to our 3.4%. Now that's a real simple approach to it, but I wouldn't mind hearing a reaction to that.
Yeah, sure. I mean, it's one of the options is to get that, make up the whole difference. So on slide 14, we acknowledge now that the difference is so low. If the board were to just choose to fund the difference out of either RSR or a different account and not make benefit changes, that's on the table for sure. We also, in the process of going from last month to this month, had solicited ideas for benefit changes from the carriers. One of which, and I'm kind of skipping to the punchline here, right?
Sure.
But I think we're ready for it. One of those benefit changes was within Kaiser Plan 1, the specialty imaging copay. So for MRI and CAT scan, the imaging copay today is $25. For MODA and also for PEB with its carriers, including Kaiser, through the ACT, the copay is $100. So that benefit change seemed like a worthwhile benefit change to make in terms of steerage and encouraging responsible usage of the plan. So I think Mercer's perspective was that might still be a worthwhile benefit change to consider, acknowledging that benefit changes are not required this renewal. So the way this is laid out, I'll tell you guys maybe how we can navigate the next couple of slides, since we're doing this more of a conversational approach.
I just want to answer Bill's question. So we have 37.3 million in that, the OEB stabilization sub account that's separate from the RSR, and a lot of it's used for wellness programs funding. But it's grown really slowly and steadily.
Yeah. Not intended.
WW is
That's a bonus program. Okay.
a wellness program, is
Yeah.
an example of that, which is 1.4 million.
I get that. But I see it growing and I'm like, okay, we should use some of that. And like, in my opinion, the hospital cap money was for long-term systemic improvements to. But anyhow, that was just something I think from it was in my brain from a previous meeting conversation. Right.
So I want to just table that question that I asked until we go through the others, but
Yeah, I mean, it's the question to ask, Jeff, for sure. There are a couple other things. So if we're thinking about how much money to spend and from which account, if we have two accounts in reality to spend from, and also benefit changes, we really have three moving pieces to get to our final goal. We talked about spending some money on a year one VERTA investment. It's a small dollar amount, that $100,500 to get VERTA off the ground. We also talked about funding RSR or using money outside of the renewal to pay for Weight Watchers an additional year while we have the time to do an in-depth analysis in CIAO. So those two things together are $1.5 million.
Okay.
And then the benefit change, the difference between the 3.74 renewal and the 3.4 target is 3.2 million. So that's what we're looking at, 1.5 and 3.2. On slide 17, and these are illustrative. Mercer's recommendation, just an acknowledgement of where the difference is and how low it is at this point. Again, we thought it would be worthwhile to call it modernize the advanced imaging copay for Kaiser Plan 1. But we also have other benefit changes just to illustrate the spectrum of options available to the board. So if we wanted to fund 0.8% or $0.8 million of that difference, so it's about 25% of it with benefit changes, what we would be looking at would be the specialty imaging copay for Kaiser, or that's roughly equivalent to a specialty office visit copay increase of $5 for both carriers, or it's roughly equivalent to increasing the ER copay from $100 to $150 for both carriers. So it's a couple different equivalent options there, depending on if we wanted to tackle ER utilization or take a more index to inflation approach with the specialty copay, focus on steerage more for advanced imaging.
Kirsten, I have a question on package one, and then I'll entertain other questions or comments. So the difference in my simplified mind on this is that with Kaiser, the 25 is different than Modus 100 because the Kaiser doctors are part of the system, and so you use the word steerage, and I'm sorry, I don't get all the terminology, but aren't they two different things then? Because Kaiser, it's part of an integrated system. So is it necessary? Is it better to raise it to $100, knowing that the physicians ordering the tests are part of the Kaiser system?
Yeah, it's true. I understand your question. By steerage, I meant, you know, what we try to come at things from multiple directions, right? We want the optimal decision to be made. We don't want to prevent anybody from having advanced imaging if it's necessary for their treatment. Also, we want advanced imaging to be saved for when advanced imaging is absolutely necessary. So maybe we try to come at that from multiple angles. And from the Kaiser system, you're right, because they're integrated. That physician has the direction of that physician's group within Kaiser. They've collectively made their treatment guidelines. So that physician is, you know, helping the member make the good decision as well. But then also there's that member component too of, is the member also part of that collaborative discussion and having the same incentive the physician has to be making that decision. And the Kaiser copay for advanced imaging for PEB is $100 still as well, even within that system. So I understand where you're coming from on that one for sure.
Any other questions on any of the packages on page 17?
So package 1 is 800,000 by itself. Package 2, is that inclusive of package
No,
1?
these are all just independent options. Just to give you an idea for, if we wanted to make up about 25% of the difference with benefits, this is the magnitude of the kind of change that we're looking at.
We had the conversation last month of if we're going to changing benefits gradually over time makes sense, because what happens is that if you don't, you actually, and we saw this, a migration to where the member component is decreasing. And then we also talked about trying to, if we're going to do benefit changes, spread them out over a larger group, you know, and have it have a less impact. So the person, you know, who's getting the specialty scans may be going through, you know, maybe it's concentrated on a smaller number of people who oftentimes are having other things happen and maybe getting hit with increased costs. So if you asked me giving those two principles, if we needed to come up with almost $1 million, a little less than $1 million, and looking at 1, 2, and 3, I think number 2 has the impact that spreads it out over a larger group, but in a level that is not going to be felt. Because again,
both carriers.
Yeah, and both carriers. So if that was the number, if our goal was to get a little less than $1 million, I would suggest number 2 based on the principles we kind of talked about last time.
But just also keeping in mind that package 0 is still on the table.
I'm also not.
It's not one of these two,
Yeah,
because
it
there
really
is
is.
package 0, and
Yeah.
you can take $1 million out of the reserve.
If we need to decide we need to pull $1 million out of benefits, I would recommend 2.
Okay, so we're starting 3.2 million back on page
Yes.
12.
So I was just flipping back, and
So if we were to take package 2, then we're down to 2.3, yeah.
I'm just reminding everybody that if we pull $3 million out of the reserves or the ending fund balance, you don't have to choose any of these things.
JJ.
Right. We can be status quo. Right.
Yeah, so I don't think we should go past option 1. I think option 2, 3, and 4 are too much out of benefits. I am in favor of option 1. I think that we should spend some more on reserve, out of the reserves, but I think some of it should come in the benefits. And I also agree, package 2 makes the most sense. It spreads it out the most. I think because we're close to 3.4, it's appropriate to use the reserve funds, a fair amount of that to cover it, but I don't think it should be 100%.
I think I would prefer continue. I hear what you're saying. Prefer to continue through the options so that everybody has all the information. Okay. Definitely hear what you're saying.
This is my first time through this process. Have we reached the limit of negotiations and the carriers bringing their costs down?
Right, yes, due to the timing of when we need to make decisions to get the rates ready for open enrollment, we don't have time to wait another month for updated experience again. So round 3 is where we're at now on the renewal increase.
So the updated experience, their costs keep coming down for medical every time they come back with a new batch of data. And is that a result of negotiations with them, or is that just their calculations changing?
Yeah, it's primarily experience emerging lower than the trend assumption. And part of the reason for that is that we're using a historical experience period, and we're using a forward-looking trend assumption. And the forward-looking trend assumption is thinking about, gosh, what's going on with inflation right now in the economy? What's going on with providers and provider fee increases? What are my costs going to be doing in 2023 into the end of 2024, really, for the plan? Really different time period. What's happening right now with the experience period is it's rolling forward from half of 2022 into 2023, where maybe we're not experiencing those very high trends yet. So as the experience period rolls forward 1 month, we're recognizing that economic reality and losing 1 month of this higher forward-looking trend assumption from our renewal calc. So it's that difference that helps the plan out a little bit. Yeah.
So when did the negotiations happen in the process? Is it like much earlier than this point?
Yeah.
Today?
We first heard from the carriers in January on their round 1 renewal financials. So the renewal letter initially goes out in December, because it's also this waiting game of, we want to wait until it's further enough along so that we have recent experience. So we're not tomorrow going to ask for next year's renewal. We're going to wait a little bit and see how did the new plan year fall out, what's going on with enrollment, can we get updated experience? So the timing of what transpired was that round 1 was requested in December, and I think we got it back towards the end of December, and then circulated that beginning in January. And then each month, I think presented to the board in February for the first time. And then each month go back and have the carriers look at things. And it's not only been the experience. We've also talked with the carriers about, well, hey, your assumption about this regulatory bill is too aggressive. You need to come off that. Or Kaiser, we realize you cap your dental increase at 0, but you need to give OEB part of their decrease. And Kaiser says, okay, we will. So there are other things going on in the background besides just the experience. It's just that between round 2 and round 3, the experience was the big driver. Okay. But through that whole multi-month process, multiple things are moving in that time period.
Just because I think I come at this from like my labor union experience, and I'm thinking like $3.2 million is not that much money to them. Like, can't we just leverage our huge membership and to get them to come down? But I guess that's not how this works.
Yeah, I think, when we look at this, we're looking at it in the totality of the dental came in over 3.4%, or the medical came in over, the dental and the vision came in under, with 3 different carriers involved. So what we'd really be talking about is we're looking at this collective number of 3.4%, but really the conversation would be, and it's the conversation we've been having, is with each individual carrier about, hey, Kaiser, let's talk about your medical and all the dynamics with your medical. And let's talk about your trend assumption and your pooling and your dental decrease cap and all of the different factors. Yeah, understand what you're saying.
Yeah.
Yeah.
Michelle, did that help?
Yeah.
Okay, great. All right. Okay, so flip back a couple of pages. I'm sorry. Oh, well, thanks. Susan.
Thanks, Robert. I just wanted to say I really appreciate Michelle's comments there. I mean, that was, in essence, why OEB was created, was to leverage the pool available. So, I mean, I understand from going through this that, round 3 is where we're facing, but it is rather unfortunate that we can't negotiate a little bit deeper on those.
bit more about what Mercer's seen in the commercial market as far as renewals? Or I know OEB's so early in the process, but
Yeah, OEB is early in the process, but, we deal largely with self-funded clients as well. And so we work, we're sort of in the position of Kaiser and MODA for our other clients because we decide on the assumptions for their renewal calc and what experience period to use and how much margin to put in trend for the factors that we expect to come, over the next 12 months with the economy and with the inflation. So we are seeing, Kaiser increases come in consistent with what we're seeing with OEB. And I do think even though we ended $3.2 million above, we're at 3.74 compared to 5.83. So OEB's influence did play a role in that progression there. We're seeing trend in the commercial market, 6.5%, 5.5%, because of course the commercial market doesn't benefit from Senate Bill 1067 and the link which links the hospital payments to 200% of Medicare. That's a factor in the renewals as well for OEB. Certainly helps with the trend. Probably doesn't feel like it to you guys because 3.74 is over 3.4%, but it is actually a really good renewal.
I could say City County Insurance Services, which is a pooled insurance that covers cities and counties, and it's much smaller than OEB, but they have Kaiser and I think it's Blue Cross Blue Shield. I could be wrong on the second one, but their rates are significantly higher than what we were able to negotiate and push to get down. So our size was a big determining factor on our ability to push and get it down lower. Not that I'm happy with 5%, but it's less by 3 or 4% than what they ended up with, a smaller pool.
There were some nice help or projection charts that were in the PEP meeting that were quite helpful from my understanding. Great to see those trend analysis, what was expected. I know I had them in my head because I went to the PEP meeting, but nobody else saw them. Or if you weren't in the PEP meeting, you didn't see this. So,
Any other clarifying questions or comments on this piece of it? Okay. Kirsten, if you want to go through options 2 through 4, well, just one at a time, right? So option 2.
Yeah, of course. So package 1 and so option 2 and option 3 really just look at different ways of combining benefit changes that we've already seen. So those aren't new options. But if you go to slide 20, so slide 20 just illustrates a couple other benefit changes that we'd asked for in response to feedback that we got last meeting, which was, if we're going to increase deductibles and out-of-pocket maximums for MODA, can we do this just on the non-coordinated care tier only? So we did ask MODA. The board isn't going to go this route, but that is reflected here in this package option for if you wanted to pay for the whole difference with benefit changes. Again, this just illustrates the magnitude of changes that we'd be talking about, not a recommendation to do that. You'd have that option there with MODA, or deductibles and out-of-pocket maximums. And then option 3 is $2.4 million in benefit changes. Option 2 was 1.6. And then that option 1 was the 0.8 million. And as Bill mentioned, there's an option 0.
Any clarifying questions or comments on options 2 through 4? Okay.
Slide 21 lays out the financials of everything. If we want to think about having both funds available on the table from which to spend, then you can just generalize the RSR label of those columns to outside funding. Everything's wanted to make sure we're carrying along the Verda investment and the Weight Watchers renewal as well.
Have we voted on Weight Watchers yet?
Did we vote on Weight Watchers last month, or is that something we had to? I know we discussed it extensively last month.
I believe it was then handed to CL.
Well, CL hasn't discussed it again. Our recommendation for Weight Watchers WW is to continue them for an additional year, but funding it out of the RSR.
Yeah. All right.
Next, our recollection was we had not voted yet, and we on slide 22 is where we have the Weight Watchers along with other wellness initiatives.
Okay, that's good to know. So we'll get there. And
What do you mean by RSR loan or RSR payback?
Yeah, so it's this idea that we talked about last month, where if we artificially buy down the rate with RSR, we just need to be in our minds budgeting to pay it back
Why?
next year as well.
Why pay it back?
What I mean is the underlying costs of the plan haven't decreased. We just decreased the premium.
Oh, okay. So we have to take that into consideration, the additional increase.
Right, and it's not,
Thank you.
yeah,
Okay.
we're not, this is more of a mental note to understand what we spend and buy down this year. We'll see it next year.
It'll come back and bite us.
Yeah.
Thanks, Tom.
That's a big reason why I'm not a fan of putting too much in RSR, because it's not a one-time expense. It will come back. It's artificially decreasing your rates, and
Yeah.
the actual increase next year will be reflective. So
But at the same time, you're putting money in there for years like this when you
well,
need to.
I don't think the number should be zero. It's for a reason. We have it to do that exact thing. We just need to be strategic with how we do it so that it doesn't hurt us in the long run.
Organization's gonna have a zero fund any balance, right? So
Yeah.
you just have to decide how it's going to be.
Yeah.
so,
Tom and JJ, you guys were interested in option 1, package 2. So that's that second row in the table on slide 21.
so if we were to insert option 0 right here, according to what Bill's suggesting, not voting on, but suggesting, what would the RSR ending fund balance look like? So we have it all on one page.
It's on
Yeah,
that
for
first
sure.
page. I mean,
Is it?
yeah, it's the first block, the first column on the page that shows them all. Sorry.
27.9?
Yeah, 7.
Scenario 1, slide 14.
Yeah, it's
27.9, okay.
That's if it came out of the hospitalization fund. If
Okay.
it comes out of the other one, then they'll each go down a little bit.
Okay.
Just
And
didn't mean
again,
to-
we can just think of that as outside funding if you guys are undecided yet where you'd like to tap.
Yeah, wherever we take it from, yeah. All right, so,
But you're presenting RSR spend as just the combined pool. So we actually have a division, how much comes out of Kaiser or how much comes out of MODA or
That's true.
both.
That's true. That's a
And I
second
think
decision.
that's another distinction we need to make.
If the chair is willing, I'd offer a motion to approve WW for the 23-24 year, funding it through the RSR.
yeah, I'll entertain that motion. I'll do the same thing for Verda, so we can
I
get
think
those
we
two
already-
off. Did we Verda?
We did Verda.
Yeah,
Yeah, we
earlier
did
today.
Verda, just as we were
Oh,
going
that's
through.
Yeah.
Okay, that's right.
Move
Sorry about
to-
that.
Move to accept WW for 23-24 funded through the RSR.
I'll second that.
Okay, all those in favor of the motion to transfer Weight Watcher, the renewal to RSR from, well, just to transfer it to the RSR for 1 year, signify by saying aye.
Aye.
Oh, sorry.
I was going to ask, what is that dollar amount?
1.4 million.
1.4 million. On this page.
So I'm gonna do the vote again real quick, okay? So all those in favor of transferring Weight Watchers, the cost to the RSR for 23-24, signify by saying aye.
Aye.
Any nays? Okay, that motion passes. So discussion around, I guess I can just start the discussion. It sounds like we're gravitating towards option 0 or option 1, 2. Do I have that correct? Or if I summarize that correctly?
2, 1.
Yeah.
Oh, is it 2, 1?
One,
1, 2.
Option 1, package 2.
Which is described on, just so everybody's on the same page.
Page 21 would show it.
On page 17 is the option 1, and then, yeah.
Okay. Discussion, please.
I can, as we look for consensus, I can go with either. I think that the idea of moving slightly increasing specialty copays is not something that is going to impact people, and gives us, again, we don't know what turbulent times we're going to have. It gives us a little bit more reserve, but if I am not strong, don't feel strong in either way.
So I'll advocate for just keeping out of pocket for our low income people as low, and then if there's other ways to distribute that better, maybe we can debate that, but I still focus again on our lower income members, that any little bit is a problem for that, can prevent them from getting shift left needed health care, and that would be bad, in my opinion. So I'm and again, I'm like you, Tom, I'll roll with it, right? I'm good, but that's what I advocate for.
Susan Miller has her hand raised.
Susan Miller.
Thanks, Robert. I wanted to echo what Bill said about keeping the costs low to the members. We represent some lower income folks ourselves, and that is incredibly important. I also would raise the question, why is it such an easy vote to take the 1.4 out of reserves, straight out of reserves, to pay for Weight Watchers for another year and not use the reserves to go ahead and offset losses to benefits? It feels like we're just kicking the can down the road about not handling the problem.
Okay, Tom has a response to that, Susan.
You're going to hear it during the CIO conversation how we're not sure if Weight Watchers is something we want to continue for ever. And so it falls into this category of not something that we need to build into rates. It's something that is optional. And we're in a holding pattern. The recommendation that came from CIO is a 1-year continuation of WW while we explore if that is the right way to spend our money. So it's viewed as that it's optional.
Can I augment that?
Bill, augment, yes.
So in CIO again, also, we're kind of coming with the thing of long range improved healthcare for our members is in the programs like Weight Watchers, and the other one that Kaiser has is Omega, or I can't remember the name, Omega. But those kind of things provide long-term changes in positive healthcare results and how much we spend. So the reason that was kind of simple, because it's an investment now, and we're not sure if Weight Watchers is the right investment, so we want to do it for 1 more year. But overall, improving the health of our risk assessment of our members reduces our long-term costs, and so we use RSR to do these long-term systemic improvements. I hope I said that in a way that makes sense.
Thank you.
So I might put a couple people on the spot because I definitely want a broad range of responses here. Yeah, JJ.
Question for Mercer. So if we were to increase the specialty copay by $5, how does that have our system compare with other markets? I mean, does that put us higher than typical?
I don't know right off. We could dig up our benchmarking deck from December. I think we covered that back then and take it on.
It would be helpful to see some examples of a specialty office visit copay. I don't even know how much one would be.
If you scroll to the back, I believe we have it as a
In the index.
slide 39. Thank you.
They're still relatively low. Yeah, they're relatively low.
I guess it's really hard to think about voting to, like, when we know premiums are going up, also voting to increase out-of-pocket costs. And when we vote in this like narrow way on this one small increase in cost, I try to keep in mind the other pressures that are on members financially, so even with just premiums going up.
Robert, just in response to that, actually the out-of-pocket costs from a percentage standpoint have been decreasing because as plans cost more, and the copays are fixed, the percentage that the member is paying is decreasing. So there's some thought that, yes, you should, let's say you should always be at 10% of the cost of care should be coming out of people's pockets, 90% being covered by the plan. What's happened is that those numbers, well, in 3 or 4 years ago, it was 10%, now it's down to 8% or something like that, just because of inflation, but the copays haven't been changing. If it's a percentage, like if it's a 20% of the cost of the visit, that's always going to adjust with that. But when they're fixed, they decrease. Now, the reality still is that particularly low-income members, a $5 increase is a $5 increase. So it's not that. The point is that it's still not impacting people, but just from if there was a right percentage of patient cost share versus plan cost, we would kind of not every once in a while we'd kind of readjust fixed copays to match that inflationary change.
So what we would add to that, Tom, though, is what kind of pay increases have they been given?
Yes.
In relationship to the increase in the cost of the premium?
And the cost of living.
Yes.
So it's all tough. I mean, I'm not
True.
Trying to.
There's a lot of moving parts.
Yeah.
But philosophically, not working with percentages from where I sit, we're just trying, we came in with a survey that was done about 3 years ago. We were way high on out-of-pocket max. Not individual components like this, but just the total of what our members had to put out if they had a not catastrophic, but even a minor or situation where they're involving healthcare, their out-of-pocket maxes were above the average. So just bringing that down as a philosophical thing to get it to where it was in range of typical others was what we've been fighting for the last year. So you see us doing it in little pieces like this, but the total out-of-pocket max is what we're trying to build philosophically. But not advocating, right? For even our lower income custodians, a bone break-in for a child is going to peg their out-of-pocket max, and that's a huge percentage of their pay, right? So that's the philosophical way of we look at it, right?
I'm not totally sure about this, but like I can definitely over the last 10 years, my out-of-pocket max has quadrupled probably.
And we would like to be better than that, right, for our members, right?
Well, I think the copay doesn't change the out-of-pocket max. I mean, it's calculated as part of that, and I would concur that our out-of-pocket max is significantly higher than industry norm. And that's something that should be part of our strategic plan over the next however many years to try to get that more in line with what other agencies have. And there's a cost to it, but it's tough.
Tom?
So I'm just adding together what our RSR now is at about 34 million. And our ending fund balance reserve, which was about 36 million. that suggests that we have about $70 million in reserve, and we're 3.2 million off.
We're 3 million out of that.
Yeah, and that's less than 5%. And
To stay current service level.
yeah,
As we say in the government,
Yeah.
that's to do current service.
yeah. So in terms of risk for the long term, off $1 billion a year proposition, it's peanuts. It's a rounding error. So I guess I'm moving more towards Bill at this point in terms of suggesting that we fund the gap by using that combination. And I don't know what the right, I'd ask, OEBB staff to figure out what's the best. But if they're mutually, if you can move them around, what the heck?
So like to hear from Bob, Bonnie, and Enrique before we call a vote.
Tom, you're suggesting 3.2 million would all come from reserves,
Yes.
and however that gets distributed, that's how it gets distributed.
Well, it just
That would be the next
I
discussion.
understand,
Yeah.
But that's for somebody else to figure
Yes,
out.
right.
Yeah, that's where I am too.
That's pretty much where I am. I think we have the reserves. We should use it. What are we saving them for? I know insurance is always going to go up. I know that, but we're still going to be building some reserves up.
Yeah.
And as someone who's negotiated packages for people who monthly salary was the same as what their insurance costs were, and they were paying anywhere from 50% of it out of their wages, I like to keep those down as low as I can and not see costs go on to them.
Enrique, anything else to share?
Yes, I echo our colleagues saying that we need to use the reserves to lower the out-of-pocket costs. We have inflation going up, and the cost of living continues to increase, and we need to help our lower-income members. And I hope that we can do a stronger negotiations next time with Moda and Kaiser to do a further study on how we can stop or decrease the high rate of increase of the cost moving forward. As last month, we asked for more data and more research on that. Thank you.
Thank you, Enrique. Is there any more discussion on package 0 or package 1-2? At this point, I'll entertain any motion that y'all have.
I'll make a motion that the board adopt package 0, pulling the delta that we need to balance the 3.4% out of the ending fund balance split, but proportionately between Moda and Kaiser, according to the numbers.
Second.
Call
We got
question.
discussion.
Yeah.
I would like to separately discuss
Oh.
how we take it out of the reserve.
Okay. Well, I'll just say.
What
take
the
it out of
balance is
reserve.
between Kaiser and Moda.
You want to rephrase the motion and then we'll,
So I'll just say with you, that the board adopt option 0, as I called it, to pull the money out of the ending fund balance reserve to make up the delta to buy us down to 3.4%. I'll stop.
Question, do you mean ending fund balance reserve or rate stabilization fund?
Ending fund balance reserve. I'm specifically saying that, very, very.
It's same bank account, just different
Same
sub
bank account,
accounts.
just
They're
how
all
it's accounted.
roll up to the same bank account
It's all in one number, but it's just
separately. Yeah.
from a bookkeeper, it's how you enter everything. in.
Okay, so
The-
those are different amounts though, aren't they?
They're different amounts, but RSR, again, it's hospital cap savings, so they were pulled out separate for Moda and Kaiser. So it's a little easier, I think, bookkeeping. That was the purpose of the RSR fund was, to buy down rates in the future. So, yeah.
So I'm kind of differing with you, Bill. I would rather spend the RSR than the
Yeah,
other.
I mean, that's fine. I'm just saying that's the way I'm putting it. but-
Anyways, yeah. fine.
So,
Yeah.
well, do we have to be specific in this motion?
No, that's the stabilization fund. Yeah.
does it get seconded? Does it get voted? So,
Yeah. So I just,
So I don't know if I can pull, I'm now in my parliamentarian mode.
Thanks.
Did that get seconded?
It did,
It did not.
no, unless Bob was close to seconding, but then there was a question right at the same time, so I did not have an answer
So
for
if
you.
it didn't get seconded, that makes life a lot easier. Just somebody confirm for me it didn't get seconded.
He was trying to second
I
it, but
really-
someone
I
else talked
attempted really
over him.
hard to second
Okay.
that.
All right, so then you can say the motion didn't get seconded, the motion fails, and we can restate the motion.
Motion did not get seconded, motion fails.
Okay.
Thanks.
So then I will restate my motion that the board adopt option 0 to use the RSR funds from our account to buy down the current proposed rates to 3.4 as. Okay. That's it. My motion is done.
I think she
I heard a
does.
second.
It's up for a vote.
Okay, we're good now.
Okay, so that was a second from Susan, is that right?
Yes.
Okay.
Yes.
Correct. I
All
second.
right. All in favor of Bill's proposal to do option 0 using the RSR funds to fund the delta to get us to 3.4 signify by saying aye.
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 Any nays? That motion carries.
We're close.
So I do believe, I need to look at the agenda real quick, but I think we're at a natural break if that's okay, Kirsten. Let me make sure. Agenda on.
Pretty close to the break time on the agenda.
Okay, so
10 minutes.
what do you want to do? Okay, let's do a natural break here. We'll be back in 10 minutes, which is 2.
We're probably live right now. So-
It does not have a light on it, so
We have video.
We have a screen. We have video.
Oh, great. Okay, so we are, if you're following along on paper, we're on page 22, is that correct? But now we have a screen.
So, and actually, we're already ahead on page 22 because of we already passed the motion on the Weight Watchers. So what we can do is we can either do these, I'll leave it up to the chair, if do these one by one or just do these as a package. Again, these are just the additional coverages. The first one is really Uprise EAP, renewing at the proposed rate for the 23-24 renewal. WebMD, this was already discussed. It was a recommendation that was brought up from CIAL, which was to discontinue it. And then Unum, that's an evergreen contract. It's just really here just for the sake of completeness.
Any discussion on any or all of these 4 programs? Okay, if I can entertain a motion.
Move that we accept the recommendation.
Second.
Okay. All those in favor of accepting the package as described on slide 22 for additional coverages, covering Uprise, WebMD, Weight Watchers, and Unum, signify by saying aye.
Aye.
Any nays? Okay, that motion passes. Let's go on to section 3.
I should have brought Oreos to perk everybody up before this conversation. So the Copay Max program, this is actually, it's an initiative by MODA, and it's a proposed benefit change. And I'll just say right off the bat that there's some complexities with the program and it might not be a good fit for OEB. There's some uncertainty there, but we just weren't comfortable not bringing it before the board for discussion because there's potentially money on the table and we wanted you to see it at least. Given the uncertainty though, we've put it here in the order of the program as opposed to right off the bat. You'll understand why as we get into it. So if you turn the slide, copays are kind of complicated. We did our best to break it down and also I'll walk us through. So what we're talking about is some specialty drugs where a member's normal cost share might be high. So take, for example, if the specialty cost share is 25% up to $175 copay, presumably that member would be paying $175 for that drug, which could be cost prohibitive for that member. It's expensive, especially if you're taking your prescription monthly. Drug manufacturers, in order to help members pay for their drugs, have set aside big pools of money for something called a drug coupon. And they allocate a certain amount for a member to use in a year towards the cost of their copay. And so the member goes to the pharmacy to pick up their drug, and instead of paying their copay, they pay the calculated copay amount minus the manufacturer coupon, which in many cases is $0. Sometimes it's small. The amount of coupon assistance that the member receives accrues to their out-of-pocket maximum, which is a little bit strange because those are not actually costs that the member paid for. The reason why that happens, it was not immediately clear to me. I was like, what do the drug manufacturers have to gain from that? But it makes a lot of sense because once the member has met their out-of-pocket maximum, there is no more copay. The plan pays 100% of all of the pharmacy costs, which lets the drug manufacturer completely off the hook. So it's in the manufacturer's best interest to get that member up to the out-of-pocket maximum as fast as possible. So the other important thing to know about these coupon budgets is that they typically don't get used up by the member copay, the actual member copay. There will be an amount left over, especially if the member hits that out-of-pocket maximum. And that today, that amount just accrues right back to the drug manufacturer. It's unspent money that they had allocated to that member that goes back to them. So slide 25 uses some theoretical amounts. So we'll say manufacturer X sets aside $12,000 to help a member with their drug costs. And the member's copay is $100 a month. So over the course of the year, that member has spent $1,200 in coupon assistance towards the cost of their drug. $1,200 has accumulated towards their out-of-pocket maximum. And there's $10,800 left over in that balance, which today would accrue back to the manufacturer. I say accrue back to, but they would just keep it, right? It's their money. And no benefit would accrue to the plan. So before we go on to the copay max, I'll just pause for a minute and ask anybody if they have questions about how it's currently working today. Okay, so let's.
I do have one question. This is probably an aside. So do the coupons reset, since the out-of-pocket maximum resets every year, do the coupons reset as well?
Yeah, it's an annual amount that's budgeted per member.
Okay, thanks.
Yeah, and this is like proprietary trade secret kind of knowledge, how much is budgeted per member.
Okay, thanks.
All right, so let's turn to page 26 and let's talk about what in that picture changes with the copay max program. So the drug manufacturer still has this amount that they budget per member per year towards the cost of the drug. That part doesn't change. The member's cost share is still covered to the same extent that it was covered before. That doesn't change either. The copays, the coupon assistance portion of the copay, so this is the part the member's not actually paying, does not accrue towards the out-of-pocket maximum in this scenario. There's a very minimal member impact, which we'll see later, because so few members actually meet the out-of-pocket maximum, but it is a detail to cover. We still have $1,200 of the $12,000 of the total coupon budget spent, so there's $10,800 left over. But the way that the Coupon Max Plus program is able to optimize the coupon, that $10,800 accrues to the plan as plan savings and reduces the overall premium for all the members. So we'll talk about the caveats and trade-offs. We've tried to be really explicit about them. On slide 27, we'll get there. But are there any questions on page or slide 26 about the copay max at a high level? Tom?
Why would the drug company give the $10,800 to the plan?
Right. Well, the drug manufacturer has set aside this pool of money to spend on the member. So the way that the copay max program works, it makes the member's cost share at point of sale look like, in this example, it makes the member's cost share at point of sale look like $1,000 to the drug manufacturer. So it says, the copay max program says, hey, if I've got $12,000 available for this member for coupons, we want to spend this amount that we have available. I'm going to divide that by 12. And so I know that really I could budget $1,000 per month from this program for this member. So the pharmacy will make it look like that member's cost share is $1,000 to collect that $1,000 from the drug manufacturer coupon program, of which it pays for the member's actual copay. So the member is no worse off. And then the rest of the money is submitted back to the plan in terms of savings. So let me tell you why we did not propose this at the start of this conversation. So there is real savings here. However, if we put ourselves in the shoes of the pharmacy manufacturer, this would not be a desirable program to have running in the background. So the pharmaceutical industry has been lobbying to have this practice prohibited via legislation. And there is actually a law at the Oregon legislature that will not be passed in time for us to know how long we would be permitted to do this, which is why we can't count on it for the renewal. It's possible, even if it got prohibited, let's say for 1/1/24, or maybe it would be 1/1/25, there are a couple months of savings to capture, in which case I see this as potential cushion for next year. That's not benefit changes. So from that perspective, it's like if there's savings available, maybe we tap into it, but it's the legislative uncertainty aspect of it that makes us not want to count on it for 10/1/23. That makes sense?
Build it into the budget.
Exactly, yeah. Yeah.
So
bunch of shysters.
So the money that's being saved here theoretically, and I do mean that potentially theoretically, is going to our carriers, not to our reserve fund, right? And then we're just hoping that they're using that money to reduce the premiums for the following year.
It would reduce premiums for the following year. So I don't know the actual, maybe Erica or Carly, the technical detail of the difference, but that unused coupon that we're tapping into, if it flows through claims immediately in that month, so we immediately recognize the claim savings.
Yeah, in fact, the plan paid on that claim.
Yeah.
So it flows through the claim experience.
Yeah, so it automatically nets against the experience. So it's not like it goes to an external fund that we then have to recognize or cash in on it. It just nets claims
By the cash
lower.
flow process, it ends up being that we have more money in our, because we didn't spend all the money we expected to.
Yeah, to a conversation we were having earlier with Michelle, it's lower experience. It reduces the experience in the experience.
That's our payout. That's what we're paying.
Okay, so the whole coupon thing, I'm not going to say it's kooky, but my question is that since this is a proprietary decision by the drug manufacturers, can they just say no coupons for you, max people?
They can. So AbbVie and Johnson & Johnson now both make members attest to the fact that they're not part of coupon maximizer programs. So they are, it's like I said, it's sort of an opportunity. It's not going to be a long-term opportunity. It's a short-term opportunity to potentially bank some savings for, to help with the renewal next year. But the there's legislative headwind and manufacturer headwind there too.
Just feels a little like trying to game the system.
Yeah.
Yep. I've never seen that work very well.
No, just an inflammatory comment.
You get one every meeting, JJ.
I know, sort of my shtick. Yeah, no, I just think that the drug companies are evil bastards, and so if we can game them a little bit, they game us all the time. Even if it's short term, I'm okay with it.
If a member is prescribed a drug, the manufacturer of the drug has to be participating in this in order to apply a coupon. Is that right?
There are the coupon, I'll have Carly speak to the details. There are certain drugs, 450 maybe, that are covered by the coupon max program.
Yeah, so it's specialty drug primarily, and the specialty pharmacies are really good about actually reaching out and working with the manufacturers to find out, is the member eligible for assistance? How
Might as well,
yeah.
So Arden, which is the specialty pharmacy for the MOTA plan for OEB members, does that all on the member's behalf. So Arden knows at the time that prior auth is approved, before the first shipment of a drug is ever made, if that member's eligible, what the value is going to be for the coupon.
Okay. I'm just wondering if this could be used to push a member toward a higher cost drug because it's covered by a coupon.
So we work with Arden very closely in that regard, that they don't pursue manufacturer assistance unless there's a prior auth approved. So unless medical necessity's been met, which could include driving towards a preferred product. So they don't pursue and use manufacturer assistance to circumvent formulary design or medical necessity criteria.
But the drug manufacturers certainly use copay assistance to steer members towards their higher cost drugs.
Yeah.
And that has been a challenge because these are usually brand specialty. Now we're seeing more generic specialties come to market, and so they don't have the assistance by the manufacturer. So we always love brand medications are safe. But if there's not a card, members will say, it's $0, and now you want me to pay $25. So that's another reason it causes confusion.
I guess along those lines, I'm wondering, to the average member, how is this going to just totally confuse them and make them not trusting, even if it is to their benefit? Right? Or will this be transparent to the user?
It's largely silent. It's largely silent to the member. There are, so because this coupon assistance accrues to the out-of-pocket maximum. For somebody who had other expenses that year, they would be benefiting from that coupon having met their maximum for them. In this situation, if we unwind that coupon amount from their out-of-pocket maximum, they would have to meet that naturally with out-of-pocket expenses. If they had an inpatient stay or something like that, their out-of-pocket expenses would accrue towards I'll call it the real out-of-pocket maximum. So for a small subset of members who have met their out-of-pocket maximum, we initially thought it was 25, but we have updated data that it's actually 20 of the 20 members who had met their out-of-pocket maximum. They would be impacted by the coupon unwinding.
Any chance of a legislative penalty when they put a stop to this for those who were participating in it?
That hasn't been the trend so far. It's not proposed in the current legislation. We would just have to stop the program and revert back towards the situation.
Not recover and pay back.
Yeah, and to be clear, the legislation requires that the coupon accrues to the out-of-pocket maximum.
Understand, I'm just.
Which negates the whole value of this program.
Why is OEB discussing this as compared to just this is what health plans do? Do we have to approve it? Is this something that we approve versus it just is part of the business practices of MODA?
But when we went to special drug supply, we had to approve that, right?
It's just a question of.
I thought this was advisory.
Yeah, is this something that we have to approve versus something MODA just does?
So that's a great question. And the reason it's broad is because it would have an impact on some members.
Okay, got it. It's the 20.
The language actually already states the way this is in placement, but the way that we actually administer those manufacturers who are assistants is accruing towards the out-of-pocket maximum today. Yeah.
And just to be a little bit more nuanced about the financials, because we really haven't talked about it, there's a couple moving pieces here. For most of the members on the coupon already getting a coupon today, their situation only gets better because now their premium is lower and also they still get their coupon. For everybody else who's not using a coupon, they're also better off because their premium just got lower as well. For the small subset of people meeting their out-of-pocket maximum, their premium still gets better, but now they have to meet their out-of-pocket maximum through true out-of-pocket costs. So we really have a couple different impacts to think about. MODA's estimating on the conservative side, it would be about 0.25%. So it's material, which is why we wanted to bring it in front of you.
But the flip side of that is that if it becomes legislatively illegal, then we have to jump up 1/4 plus whatever we're adding for inflation.
No, because we're not factoring it into the renewal specifically so that that doesn't happen. So what we would propose is that MODA would turn on the program. It would be running in the background. It would be reflected in OEB's improved experience.
Yeah.
We've got a year's.
Just going into the reserves because we're not paying out as much as we thought we would pay out.
Yeah. And if it goes away.
You don't have to go retro, so you don't have to pay it back. So,
Yeah, but if we kept it going for a couple of years.
Kept it going for a couple years and that's.
If it became illegal, then we would have to jump up and make that up.
Yeah, right. We'd have to make that.
Right.
But we would have, if not having it, we'd be there anyway.
I'm just looking at all the consequences down the road. Right.
So are you looking for a motion to approve the copay max plus plan?
so maybe, let me think about this for a minute. Is there any more discussion on this first, right?
Going to be reflected in the rates we're doing today. We can spend a month thinking about this.
I think they want to turn it on now. The sooner we turn it on, the more.
I thought it says October 1st, 2023.
If we could, operationally, we can turn it on, probably need like a 60-day lead time. At the most, I would say. So we have the ability to turn it on whenever.
Yeah, and I would, Thanks,
I
Carl.
see. Yeah, if you want to, I agree with you. If the implementation plan is for October, that's what you want.
This just seems like a shell game to me.
I move that we approve this and have it start as soon as operationally allowed.
I'm gonna second it.
We have a motion and a second to approve the MODIS proposal on the copay max program.
My discussion is that we just pay attention that if it does get into our rate discussions in a future year, that we be cognizant of it, right? That it could have a detrimental effect if it went away after it's already been incorporated into our next rate discussion.
Agreed.
So I have a question. Did you say this is transparent to the member?
No, I think it's mostly silent to the member.
Yeah, so it was.
All right,
it was
yeah, that's what I
triggered.
meant, silent.
Yeah.
So they're unaware.
Except they'll hit their out-of-pocket max a lot faster than they were expecting.
It's
Right.
transparent in that the member handbook currently says that copay assistance does not accrue towards manufacturer or so towards maximum out-of-pocket cost. So
Well, I appreciate knowing that. What I was intending to address is, are we making him, this does not make it any more complicated for the member?
no.
Okay, thank you.
All right, got a motion and a second.
It's kind of
Oh, Enrique.
Yeah, so on that question, I guess I want to make sure that if we have members that are going to be impacted by this, they are aware of the change. I mean, what sort of communication are we going to have?
Yeah, we can do any communication. I mean, so there's, there are, I was just pulling up the numbers right here. Oh, go ahead, if you have them say.
Lower cumulative claims liability.
So there's, who met out-of-pocket maximum and then kept spending more money, right, after they met their out-of-pocket maximum. So those 10 members
This one seems.
would be impacted by the change. So we certainly can give a, whatever it is, 60-day notice, if that's what we'd like to do, if we're looking at an as soon as possible implementation. We can message those 10 members to say this change is going to be effective on such and such a date.
Well, I would appreciate that communication. Who's someone who, you know, only 10 people, but I think it'll be professional of us to let them know. Thank you.
All right. Okay, I'm going to call the vote then. All those in favor of the motion to turn on copay max plus program, signify by saying aye.
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 And nays.
Nay.
Okay, the ayes have it. Ready to move on.
Now for something totally different. We're going to be talking disability. So, and I don't think this comes as a surprise. I think everybody's aware of paid leave in Oregon. You know, that's, you know, in place, you know, from the beginning of the year. So people are already paying into it. And then the program will actually start, people can start drawing benefits on September 3rd of this year. And so, as you might imagine, this has an impact on the OEBB disability program. So our purpose today is to walk you through some of that impact, and then what does that mean for your plans today, and how do we, you know, what considerations in terms of both short-term disability plans and long-term disability plans, because it'd be too simple if it was just short-term disability plans, but it impacts both. And so it's really, how do we align? So the thing is, it's like recognize what's going on, realigning the plans, and then a recommendation in terms of, you know, which plans to eliminate. We're also adding some plans back in. And that's really what we're going to be walking you through today. So moving right along. And I think the first question we're trying to answer is really, with paid leave Oregon, why is there still need for a short-term disability program at all? And that's a reasonable question. So let's start with that question. And you know, why, you know, I think that, you know, the answer to that question is that, you know, I think there's a point that you could actually use up the benefit. the paid leave Oregon benefit and be left with nothing. So the thing is, and let's back up a little bit. So the paid leave Oregon benefit is pretty generous program. So essentially, it's for family leave, it's for medical leave, and it's for safe leave. And a little deeper dive into those. So the family leave, we're talking about care of a family member, birth of a child, bonding with a child, either your from birth child or adoption or foster care as well. Medical leave, that's care of yourself. And then safe leave, this is related to things like domestic violence, people who are victims of domestic violence, and stalking and things like that. So that's the program at a high level. There's 12 weeks of benefits, and then after those are exhausted, you'd have nothing if you didn't maintain your short-term disability program. There are also other things that the short-term disability program offers that aren't offered in paid leave Oregon. I think that's another consideration. Another key consideration of keeping a short-term disability benefit is really to make sure that people who reside that are your employees but who reside outside of Oregon still have coverage. So that's so those are some of the rationale for why to retain the short-term disability program.
A couple of questions, John. You go first.
Is there a minimum benefit?
Yeah, there is a minimum benefit.
It's like $50 a week or something like that.
Oh, for which one? For the paid leave?
Short-term disability.
Yeah, it is. It's around 15. Yeah. Yeah. Isn't it? Yeah. 15. Yeah.
So the only way that short-term,
1.5. Yeah.
I think the Latin is de minimis.
so the short-term disability it runs concurrently, right? So really the only way that it would be used is if you have another disability. Is that right? Or am I looking at that wrong?
With paid leave Oregon, you could have a situation where someone went out on a maternity claim, they went on bonding leave, and they used up their 12 weeks. And 4 months down the road, they step off a curb and get hit by a bus. So they have no more paid leave Oregon benefits available to them because they've used up their 12 weeks within 12 months. So at that point, the only coverage they would have would be short-term disability. So your short-term disability would actually pay for the entire thing.
So the short-term disability is it's really for really unlucky people then?
Correct.
Okay.
Or those who live in Idaho or California.
So I have a question on that.
No, Washington has their own, yeah.
You don't have to use up your paid buckets before you use paid leave Oregon. So if you had a certain amount of short-term disability, that can remain there.
No, the short-term, if you're out for your own health condition, paid leave Oregon and short-term disability would run concurrently.
Okay. But it's not that one has to be used. Well, the paid leave Oregon has to be used before.
Paid leave Oregon is considered primary.
Yeah, and that's the key thing. So your short-term disability plan is secondary to paid leave Oregon.
Thank you.
Can't be mandatory anymore, right?
Another question.
Please do. I have a couple more to do, so go ahead.
It seems to me that we've had a couple of rate reductions on our short-term disability plans because they haven't been highly utilized. Whereas there is. So, this, if you get hit by a city bus in the crosswalk at noon, you've got double payment here. What kind of volume have we had in our short-term disability plans?
Well, you still have a fair amount of volume. We've been reducing benefits because we have a large claim fluctuation reserve account. We're trying to keep going out.
Okay.
So, one of the things John's going to talk about is what we want to do about the rates going forward. They're going to drop dramatically because there's not a lot of benefits, not a lot of value to the most folks with it.
Yeah, it's about 80% drop in the.
That was presented last month.
Yeah.
So before paid leave Oregon, I understood why sometimes we go mandatory, sometimes we go voluntary. I can't envision how that decision changes when you're talking at the local level. For example, when a local union's bargaining with the employer on whether it should be mandatory or voluntary. And so I don't guess I have a question here. It's just I don't know what type of guidance to give with short-term disability anymore to our local unions.
Yeah, I mean, I think that's going to be one of the challenges of this whole thing is communication. Because I think people are going to be trying to understand what is the value of this benefit with the implementation of paid leave in Oregon. So I think that that's going to be one of the key things is helping people understand the circumstance why they might want to keep this benefit.
So my last question, I promise, is if all employers and their unions agree that it's just voluntary, they go to strictly voluntary, does that destabilize the overall program?
Yeah, that's David's question. And there's plenty of time for more questions anyway. Should we just move forward though and just, so the first slide, as we move to the next slide, this is just the plans that will remain. So that's what we're trying to display on this slide. And this is just short-term disability. So let's, this is not long-term disability yet. And so, just at the high level, this is a movement from 30 plans that you have today down to 9. And the rationale with these reductions, the rationale behind them is that we're removing the plans that have a 60-day duration because it doesn't really make sense to have those anymore with paid leave Oregon in place that has 12 weeks. And the other thing that we're trying to accomplish here is, so there's basically 3 flavors of these plans, right? You have the voluntary enrollment employee paid, you have the mandatory enrollment employee paid, and then you have mandatory enrollment employer paid. And so what we're trying to do for each of these types that we're having, the same benefit level, the 60%, the 66 2/3%, and the 70% for each. So the thing is, that's what we're trying to get to in terms of a landing place. And so what we're actually doing is bringing back some plans that had been retired. So we're bringing back Plan 46, 47, and 29 and 30 just to round out. So people in each of these who have each of these different types of benefits have that full range in terms of the benefit level. So hopefully that helps explain that. Any questions? Because now we're going to dive into the LTD plan, so the long-term disability plan. So the thing is that, so it's really an realignment of short-term disability, and then you also have a realignment of the long-term disability plans as a result of the implementation of this state benefit. So in terms of the long-term disability plans, there's also a pretty significant trimming down, not to the same level. So we're going from about 26 plans down to 15 plans. And we're doing this by removing plans that have 60-day waiting periods, because again, this doesn't make sense in the new context of the paid leave Oregon. So that's what so I think it's easier, rather than going through and what all the changes we're making one by one, we're saying, here's the rationale for the change, and what you're seeing is the result of that the realignment of the benefits as a result of that change. And so that's also true for the next page. If you go to 33, so the thing is, what's happened with the long-term disability plans is the elimination of those with a 60-day waiting period. Any questions? If not, we'll move to 34, and this is really packaging all of the things that we just talked about in one place. And then it also details which plans are being eliminated, which plans are being retained, and which plans are being added.
Enrique raised his hand.
Oh, Enrique?
Yes, hi, thank you. Very informative. I just have a quick question. I mean, there was a reason why some of those plans were retired, right? And the board members who were there approved it. Now we're planning to reinstate some of them. so maybe for me, maybe not for this meeting, but maybe an email can be sent out on say the pros and cons on, hey, this is there's some over retired then, or they're not cost effective, or the benefits were less, or I don't know. I think that'll be helpful to explain to the daily user who, when they go pick up their or choose their benefits. That'll be all. Thank you.
I can answer that really quickly. The prior plans that we're bringing back were removed because there was no enrollment in those plans at the time. And so now, to John's point, we're trying to round it out so that we're offering the same benefit offerings for voluntary and mandatory. So that's why we're bringing those 4 plans back.
Okay, fair enough. Thank you very much.
Yeah, and I think that also there are 2 LTD plans, if I recall correctly, that were being eliminated for the same reason, that there was no enrollment. And those were plans that had a very long waiting period, I think 180 days. I think that there had been a need for those maybe a couple years ago in terms of achieving a certain price point, but they really no uptake.
So what's the crosswalk for moving people from their existing choice to one of the new ones? How's that going to work?
I think it's, I think you really have to kind of look at their current benefit level, and it matches up to another plan. So the thing is, if they're on a 60-day, something with a 60-day benefit, then it would go to a 90-day benefit with the same level.
It might make sense to point out that the paid leave Oregon plan is being paid for out of people's paychecks. And people may or may not be aware of that. Some employers are picking up the costs and others aren't. And some unions are negotiating to have employers pick up the costs. So I think if people know that they're already paying for paid leave, they're probably less likely to sign up for additional disability insurance on top of that.
Which I have a follow-up question. Just off the top of your head, what's the percentage of your short-term disability plans that are mandatory or subscribers, however you want to phrase that?
Exactly. I mean, we had more mandatory plans than we had voluntary plans. Just because you have the mandatory employer paid and the mandatory.
No, yeah, I meant subscribers, not plans.
As far as enrollment is
Yes,
concerned?
enrollment, right. Okay, thanks.
The plans, and that was the other thing, the plans that we're bringing back some of those because the corresponding short-term disability plan was being eliminated. So in order to have a short-term disability plan to replace it, we brought one of those 4 plans.
Oh, yeah, I get the matrix and why all that happened. This is more like when we have contract language that requires mandatory in certain contracts, right? And as you know, as a union advocate, I got to think about whether or not that should even apply or not. But if we totally eliminated the mandatories altogether, then I wouldn't have to do that work. So, yeah, go ahead.
I mean, personally, as an employer, I can't fathom a world where I would have a mandatory short-term disability in the current paid leave Oregon, but some may, and they may have contracts that warrant it. So I'm in favor of accepting the recommendations, even though I think long-term we'll end up eliminating mandatory, but I think in the first year, it's a good idea to keep them.
The mandatory employer paid plans are typically union negotiated plans. And so I think that will be kind of the message. I guess the question was, how do you move from one plan to the other? I think that's the message to these individual school districts is if you had a union negotiated plan, a mandatory plan, you need to look at how they're changing.
Yeah.
All right, any other discussions? We're on slide 34. There is the proposal. I will not read the entire thing, so. But I will entertain a motion if there is such a motion.
I'll move to accept recommendations.
Second.
Okay. We have a motion and a second for the proposed disability plan, the recommended changes. All those in favor signify by saying aye.
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 Any nays? All right, that motion passes.
So what's the cost? I mean, is this going to be like same type costs to,
Huge drop in.
that's why I was thinking it has to be a drop.
80% drop, yeah, it's a 80% drop.
But the claims dropped from like 1.7 to 100,000.
It'll be way less.
Yeah.
All right, I think we're on next steps, number 5.
As far as I can tell in my notes, there are none.
Wow.
Because we got through all of the decisions that were on the schedule for today.
All right. I need to get back on my computer and look at the agenda, so. Oh, is it CL? Yeah, please do. That'd be great. Just want to say thank you, Mercer, and thank you, carriers, for working together to get us to 3.4. Okay. Bifocal time almost. Okay, there we go. That's so much better.
This is the agenda right here.
Oh yeah. Okay, so it is time for the CL update. Tom?
Okay, so we had 3 presentations today. First was an update on MODA's Behavioral Health 360 program. It's been in operation now since October 1st. Rationale was to improve access, which was acknowledged to be difficult throughout the state and nationally, and increase and change the interaction with providers so that they're focusing on outcomes. Problems with mental health and behavioral health access was a problem before the pandemic, and needless to say, with the pandemic, there was a huge increase in anxiety, depression, substance abuse, and on. And it was in that setting that MODA developed this new program. Part of it is behavioral health champions, which are part of their intake process. They are now there to help their members obtain appointments, confirm that there's fit between the patient and the provider, and then confirm treatment progress, which is usually follow-up 4 to 6 weeks after visit. Also, a selection of new vendors. Probably the most prominent one is Spring Health, which deals with patients age 6 and above. It has rapid access in the matter of several days. It has 30 languages covered, or over 30 languages covered. It deals with LGBTQ plus populations. The vast majority of their providers have after office hour time, basically outside of the 9 to 5. They also brought on a company called Gemini, which does video modeling for children with disabilities, particularly kids with the autism spectrum disorder. This is particularly important for expansion of services into rural Oregon. And then they also have links with Hazeldale, Betty Ford for substance abuse. The final component of this is value-based reimbursement process that I'll discuss a little bit more. We're trying to figure out, we know what the numerator is for number of members that the behavioral health champions have dealt with. It was 245. We're waiting to see what the denominator is to understand what impact, what percentage of their members seeking behavioral health care are using the behavioral health champions. As said, Spring Health has access in 1 to 3 days for appointments. The 3 largest of the most common of the concerns were depression, anxiety, and eating disorders. They have, in terms of new member out, they have a new member dashboard launched in January with personalized programs that connects people to these various programs, so that a lot of people are actually able to go directly to like Spring Health as compared to needing the behavioral health champion. Around the value-based reimbursement, they're looking at both outcome-informed care using measurement tools and reporting, coordinating with champions, and also a total cost of care measure. They have a 6% incentive payment, which 4% if the providers just participate in the program in terms of feeding back outcome data, and then a 2% if it manages and helps with total cost of care. For those of you who don't know, having a mental behavioral health issue has huge impacts on also their physical health. It spreads. Probably the most difficult issue ongoing is the concept that Jeff raised, which was kind of how do you measure completion of care? In other words, when is the person better and when do they no longer need treatment? There's no uniformity for it, but at least by starting to ask the questions and having reporting, it will move things along. So that was the first presentation. The second presentation talked about how are we going to address issues that were raised earlier in the year around innovation in medical care. The first one was doula coverage. Doula is a person who assists, is a lay person who assists women who are pregnant and then going into labor with that process. They oftentimes are culturally sensitive for individuals, and we think that one of the areas of health disparities is the lack of again, culturally appropriate care, and this is one of the ways that we think that that this can be addressed. Medicaid already has this in progress, and both Kaiser Permanente and MODA are in that process. So we're already going to get information about doulas. Some of the problems with doula coverage is that there's no licensing. There is a credentialing process, but we have asked our health plan carriers to work with Mercer, and they also will involve PEB and Providence, and we'll have a report kind of coming back of how do we bring this type of coverage on in October of 2024. The next area that we talked about was holistic metabolic treatment, and this has to do addressing the issue of metabolic syndrome, oftentimes associated with obesity and the development of diabetes. We talked a little bit earlier about WW, or Weight Watchers, and we are going to find out what their role is, how effective they've been, and whether or not there's better alternatives in the community. And Mercer will get together again our health plan carriers, including Providence, because we'll do a combined OEBB process. And that's on the, the far end, the left-hand side of the equation of the metabolic syndrome. And then on the right-hand side is we're going to be looking at weight loss, drug coverage, and actually try to get the whole constellation of what are the options to help people who have, let's say, who have obesity, who have pre-diabetes, who then have diabetes, and try to build first a foundation of lifestyle changes that make a difference, and then see what interventions are going to be right. And again, this is it will be a dual process of our consultants and our health plan partners, with involvement of CIAO members at their request, and OHA. I think that we're going to try to outreach to the vice chair of PEB, who is a member of a physician and a member of OHA. Any questions about those? The last thing that we talked about was dental clinical targets. This is something that I've been trying to work on for about 5 years. And and we were able, after having our first in-person CL meeting since February 2020, able to address again. There are new clinical targets that we're aiming at for the dental programs. One of them is prevention services for adults, measuring that during a calendar year. A plan year. Prevention services for children and oral evaluation for adults with diabetes. And we agreed that the plans are different enough that it made sense to look at them individually and see what combinations for reporting structures around these clinical measures were appropriate. Delta Dental has very high comparative to Willamette Dental and Kaiser Permanente Dental for those first two, the prevention services for adult and children. Their request, and it's something that when we get data we'll look at, but their goal is to maintain these high levels of prevention services. For Kaiser Permanente Dental and Willamette Dental Group, the agreement was they will divide their populations into people who are at low risk and those who are at above low risk. And there will be, because in those two managed dental programs, they have different recommendations in terms of how often people should be seen. Those two plans also will work together to come up with common targets. Particularly for adults, again, where they're going to be looking at the two different populations. All three of the plans will report then for prevention services for children. Those two metrics are ones that have been agreed upon by OHA, actually, as has oral evaluation for adults with diabetes. Here, though, there's again the difficulty of how does a dental plan know that the individual has diabetes. For Delta Dental, about the guess was 80% of the people with Delta Dental also have Moda Medical, and similar for Kaiser Permanente, who have Kaiser Permanente Dental also have Kaiser Permanente Medical. Those two plans can find out their diabetic populations, and they'll report on that 80%. Willamette Dental doesn't have any links to health plans, so doesn't have that information, but in their electronic dental record, they ask the question, and there's a specific field for those with diabetes. So they'll be able to identify their population from a self-reported basis, and we'll start getting that data. So we're just coming out of, for dental services, both for prevention and then this issue around, for the prevention services, we're coming out of the COVID pandemic hole in terms of services delivered, and we'll start getting baselines, and we'll be able to, over the next year or so, be able to come up with targets that then get included in performance guarantees, we hope. And for the oral evaluation of adults, we'll be able to again get baselines. As compared to medical, we don't have comparisons, national comparisons. In the medical area, we have HEDIS and all these national standards or measurements and benchmarks. We don't have that. We're going to have to essentially create our own benchmarks for dental clinical targets. That's what I have.
Okay. Tom, was there any action we needed to take? I don't think there was, but it's showing up.
The only thing that we did was the Weight Watchers we had recommended, and that's been incorporated. So nothing else was part of this.
Thank you, Tom. Any questions? All right. Well, we were moving on to other business and public comment. I just want to start by saying I really appreciate the board and the conversation we had today, and it was invigorating. I really appreciate seeing you all in person too. We do have one public comment. If you have not received it already, it's in writing, and it'll be posted on the OEB website. Are there any other public comments? Do I ask?
Did you want, are we going to, what would you like to do with the public comment? I mean, it had a benefit request.
Do you want me to show it, Robert?
Yeah, let's do that.
Do you want us to, do you want to assign, do you want CL to look at it? How would you like to address it?
I think CL can address it. I mean, we've already made our plan decisions for this year.
Right.
This particular request is about in vitro fertilization. So we can take it into consideration for the next plan year. So yes, we could have CL look at it.
And the only change of that, of course, would be if there's apparently legislation that's in the works to require coverage.
And then that would be covered anyway, right? So, yeah.
And if I remember, it was the rate implications was 0.6% for MODA and 1.3% for Kaiser Permanente.
You're so much better at numbers than I am and memorizing them.
Is it up?
Yep.
It is up.
Okay.
Michelle, yes, first.
Do we respond to these letters in any way, or can we?
The answer is I don't know. This is the first time we've gotten one since I've been board chair. And so.
We actually got one. We should respond.
Yeah.
I mean, it takes a lot to write a letter like this. I mean,
Yeah.
it's very, I mean, and it's public record. Like I think this member is making themselves really vulnerable, and it would be nice to.
We'll definitely respond.
Okay.
Yeah, there's no requirement by the board to have a discussion over the public comment, but other than, CL will take it up and keep them monitored on existing legislation being proposed at the legislature, and basically keep them updated. We'll thank them and definitely show our appreciation too.
Okay.
And we don't have it in any bylaws that mandate a response. It's sort of the discretion of the chair whether we allow it or choose to do it. But it's been our practice. It's pretty rare we get public comment. It's been our practice to either have staff or board members respond just out of, not just courtesy, but out of respect for the person who sent it. So.
And then is the response also public record? Like, does everyone get copied on a response, or?
Depends on what we do, but often if it's staff who's going to reach out, then it's not a part of the public record.
But I think that, I think it's reasonable for us to share what the board is going to do. And, it was, we'll obviously follow if that coverage is included in that new legislation passes, we'll obviously do it. Number one. Second, we'll, while we don't have time to be able to add it to this next year's plan year, we'll put it into our request for new benefits for next year.
Okay. Would it be possible for me to get a copy of the response, just because I get this question a lot from our members often enough that I would like to have something to be able to say to them.
It should be wonky and nerdy, because I'm an ex-mayor. If you get it, the board has to get it. It can't just you get it, we all have to get it then, which is fine.
Okay.
And then the other thing is that even if you say public record, so that whatever response Ollie's team sends to this person is subject to public records request if anybody asks.
Okay, but you have to request it.
So
We will absolutely copy the board.
Thank you.
Great. Enrique.
Yeah, I understand that we want to respond to the public comment, but I would like us to maybe ask other state agencies what is it they usually do. I've been part of another board that public comments were not responded on the spot or afterwards. The board would listen to the concerns due to the potential controversial or legal issues that public comments can be, bring. So I don't want to get us into the habit of responding to public comments and later we don't want to respond and it comes back and backfire. So I do appreciate the public comment of the individual and has a thoughtful request. So I think that we just have to be careful. That's it.
That's why you have staff.
Yeah. Yeah, I share that concern as well. I think I mentioned that last time. So. All right. Is there anything else for the good of the order? All right. Well, then this April session is closed. Oh, and we don't have a second April session now, so you're welcome.
Yay.